Good morning. Pam Larson told me that she's told you that we're starting, and I'm not to make her a liar. So we're going to start. I know everybody's still coming in from the terrific roundtables that we just had. So it's my pleasure to be able to welcome our morning keynote speaker, David Blumenthal. And I know all of you know him and very well. He's the new president of the Commonwealth Fund, and you were saying it's just 3 weeks? I was thinking it's been a while. And also chair of the Commonwealth Fund's Commission on a High-Performing Healthcare System. So previously, he was professor of medicine at Harvard Medical School and chief health information and innovation officer at Partners Health System in Boston. And then before that, he was the national coordinator for health information technology under President Obama. And his full bio can be found in your folders, your conference folders. So David has been kind enough to take on the very challenging topic of, we already know how to fix our healthcare system, so why don't we? And with that, David.
So you're going to hold me to that topic, huh, Janet? Thank you for having me. Pam Larson was reminding me of a commission for the National Academy of Social Insurance that I chaired on chronic illness and Medicare. That was a few moons ago. It does seem like the world has a way of repeating itself. Can you all hear me? Is I back there? Yes, okay. This topic is actually a nice way for me to segue into some work that the Commonwealth Fund and its Commission on a High-Performance Health System just finished, a report on confronting costs. And while that report is not focused solely on the Medicare program, it does have major recommendations for the Medicare program and also affirms the, I think, core insight and critical truth that the Medicare program's reform and improvement cannot be separated from the reform and improvement of our healthcare system globally. That is not if we want to make Medicare work better in a humane and effective way. So what I'm going to talk about today, if I can make this work. There we go. I'm going to talk very briefly about the problem, which you all are very educated on, the problem of a low-performing health system. I'm going to talk about some of the, just mention what you also are well educated about, which is that we do face substantial obstacles to reforming that system. And then I'm going to talk about some solutions in two flavors. First of all, the way the Affordable Care Act can be viewed in terms of the framework of problems and obstacles. And then the way that our new report on confronting costs can be viewed in that same context. And then I'll talk a little bit about some of the recommendations from the Confronting Costs report. So our broken system, extraordinarily problematic, high cost, disappointing quality, and coverage which, while improving slowly as the Affordable Care Act gets implemented, still confronts us with enormous coverage uncertainties as we implement the Affordable Care Act, and then as we bring more undocumented aliens, illegal immigrants into our system, hopefully we will face the challenge of covering them as well in the context of the new law. So we haven't mastered the coverage problem either in the current context. Now, to think about how to address the problems of the healthcare system, I want to remind you in an overly simplified way of a conceptual framework that actually was advanced by the Quality Chasm report of the Institute of Medicine. This was at the back of the report, and it was actually much more complicated than this, but I can only think in very big abstract terms, and detail gets me all confused. So what I've done is tried to put forward the idea that there are really two big influences on health system performance. One is the microsystems and how they function, and I'll tell you what those are, and the other are macrosystems and how they function. So what do I mean by microsystem and macrosystem? And I think this framework helps us think about why it is that good ideas don't replicate in our healthcare system. So, microsystems. Microsystems are where I spent a lot of my life as a primary care physician and as an attending physician at Mass General Hospital and Brigham and Women's Hospital in Boston. Microsystems are where the rubber hits the road. They're the sharp end of the healthcare system. They're a physician's office, a nurse's office, an intensive care unit, an emergency department, a floor on a hospital bed, a community health center, actually more, not just a community health center, but a wing of a community health center, the dentist suite or the primary care suite or the specialist suite. They're places where people needing care and people providing care come together to do their work and to be served. As I said, analysts call these the sharp end. Now, the other thing is macrosystems. So macrosystems are the things that people in this room, and I in my role as a policy analyst and a scholar, often spend a lot of time thinking about. And these are the regulatory, governmental, organizational, institutional, professional organizations, norms, forces that swirl around the microsystems. These are called, in systems analytic terms, the blunt end of the healthcare system. And it's widely assumed that macrosystems have huge impact, are often determinative in terms of performance. But they are also often invisible and, in fact, hard to imagine or understand when you're working at the sharp end. The sharp end, people at the sharp end are worrying about the treadmill they're on. They're worrying about 15-minute visits. They're worrying about whether a patient shows up in the operating room on time. They're worrying about whether medications are in short supply and missing, as they often are right now, for complicated reasons. They're worried about the occurrence of a hospital-acquired infection, but they're often unaware of all the influences that may affect the rate of hospital-acquired infections. But government programs, payers and their organization, consolidation in healthcare markets, the size of organizations, their integration, the policies of accrediting organizations, the conditions on which payers pay or don't pay, and government policies constitute the macro systems in which these microsystems function and are often deeply affected and sometimes limited in what they can do. So I spent a lot of my life as a health services researcher and also as a provider of care. And the fact is, it's a lot more tractable to study and innovate at the microsystem level. You can do a reasonable experimental design by randomizing patients or maybe units of an institution to do two different arms of an intervention. You can develop interesting new ideas and implement them and maybe show an effect. We read constantly of changes in our healthcare system, experiments that have resulted in 20% reductions in cost and 20% increases in quality. Those are all studies that are rigorous enough often to be in peer-reviewed journals, and the way they get to be rigorous is that they occur at the microsystem level, where you can actually identify patients, accumulate a sample, impose an intervention, characterize the intervention, write it up, study the results, have a manageable paper, and publish it in the literature. Now, there are many, many microsystem changes that have worked over time. Primary care, well used and well deployed in organized systems, has enormous value in reducing the rate of hospitalization and the rate of emergency room visits. CDSS on this slide is computerized decision support. There are dozens of studies in the literature that show the value of presenting clinicians good information on what to do at just the point that they need to make a decision about what drug to prescribe, what radiology test to order, which specialist to use. The shared decision-making protocols that emanated from the Dartmouth group, multiple studies in the literature showing that they can reduce rates of use of elective surgery. So many, many examples of microsystem interventions that work. And some of these rise almost to the level of macrosystems. So you can go visit the Virginia Mason system in Seattle, or the Theta Care system in Wisconsin, or you can go to visit a Kaiser Permanente system, or you can go to the VA, and you can see changes that are truly remarkable, that are the envy not just of other systems in the US, but which people troop to from all over the world to learn about. And yet, these magnets and beacons of change do not replicate. We can't make them turn around the system and become high-performing. So the question is why? And I think the problem is in our macrosystems. Why are we lost in translation? What is lost about this problem? And my view is that we've failed to create macrosystems that support and encourage the use of the solutions that have been proven to work, thereby actually changing the way in which performance occurs in hundreds of thousands, millions of microsystems around the United States and around the world, and that added together create high performance. In other words, we have not made it easy to do the right thing and to do the things that we know work. Matter of fact, our system makes it extraordinarily hard to do the right thing. You have to overcome obstacles. You have to be heroic often to do the right thing. So we have these beacon systems where leadership has been so powerful, where people have bucked the trend, where they have put their careers on the line to make change possible, to demonstrate that it is possible. But they will always be the exception because they are heroic, and they need to be heroic to do these things. They need to bring their board around to say, we can manage the reduction in revenue from reduced admissions, from reduced radiology ordering, from potentially reducing our occupancy rate, from orienting our care to the outpatient and ambulatory sector away from the inpatient sector, from doing more prevention, from doing all the things that make sense. We should invest in an electronic health record system because it's the right thing to do. It makes care better, even if it doesn't contribute to our bottom line in the short term. Now, the fact is that people demonstrate these changes in heroic activities, but most people are not heroes. And we can't expect human beings to be heroes day in and day out. We have to make it easy, or at least not hard, to do the things that make sense. So, What are some of the things that make it hard? Well, there are many. We can count many of them. There are professional obstacles. Professional autonomy and the desire to protect it is a big issue. My colleagues in the medical professions and in the nursing professions highly value their freedom to make decisions as they see fit for their patients. Every one of these organizations that we discussed, hospitals, nursing homes, community health centers, they're bureaucracies. They won't change just because someone waves a wand in front of them or writes a paper saying that they should change. Their leaders need the political will and the organizational momentum and the cultural wisdom to create change in their organizations. There, of course, is a malpractice system which is dysfunctional. Misaligned incentives gets a lot of attention, and it's a very powerful disincentive to change in our current system. We have a very ideological healthcare system in the United States. It is reflective of the ideology of our country as a whole. It's a confused ideology. We simultaneously expect healthcare to be treated as a public good, but to be organized as a competitive market. Reconciling that is a very interesting idea, a very interesting problem when you get down to local markets. We have huge knowledge gaps in what actually is best for patients. And of course, in this town, we should never forget that politics plays a role. But there is, I think, some good news. You can see the Affordable Care Act, greatly oversimplifying, as a huge macrosystem intervention. Not the coverage part, though that's extremely important, and it does have macrosystem effects. But as we talk about a high-performing health system and how to achieve it, the Affordable Care Act makes major progress in ways that 5 years ago would have been hard to conceive and hope for. The question, of course, is, will we realize the promise of the Affordable Care Act? Now, what are some of the things the Affordable Care Act does? Well, it really fills our toolbox for constructive change. It's just full of any idea that you could think of. As a matter of fact, maybe too many ideas. It's got value-based payment, it's got quality reporting, it's got medical homes, it's got bundled payments, it's got accountable care organizations, it's got penalties for avoidable complications, it's got penalties for readmissions, it's got the Center for Medicare and Medicaid Innovation, it's got the dual eligible program, it's got just tons of stuff oriented toward making macrosystems work better, to addressing some of these obstacles to change. I also included meaningful use in there, just even though it's not part of the Affordable Care Act, I couldn't not include it. So this is good news, but there's also a challenge. We have all these new authorities, and we have enormous urgency to make them work to avoid the pending threat of dramatic reductions in public payment for systems, for the entitlement programs that are the subject of this discussion to some degree. And these are not programs that fit easily together into a synergistic or comprehensive form of intervention. And yet that is precisely what we need if we're going to avoid increases in the retirement age, increases in co-payments, increases in premiums, dramatic reductions in provider payments, all the things that are on the table to deal with pending budget constraints. So what to do? This is where I think the confronting cost report that we issued recently provides an example. Let me just see if I've gotten ahead of myself here. Okay, so we face a couple of broad alternatives, and which I've just been discussing in broad form, but I think they come down to two main choices, and my colleague George Halverson, who sits on our Commission on a High Performance Health System, phrases this choice as a choice between rationing and re-engineering. If we can't use macrosystem changes to change the way we deliver care, we are willy-nilly going to be driven more and more into rationing care. It will take the form of benefit and price reduction. It'll take the form of the premium support system. It'll take the form of reduced payment to providers, leading ultimately to less access to care. But that's the fork in the road that we face right now. So fundamental delivery system reform is one of the alternatives that we're facing, as opposed to these others, which I think broadly come under the category, ultimately, of rationing. So how do we take the promise built into the Affordable Care Act and into the many positive microsystem changes that have been on the table in recent years and knit them together into a comprehensive strategy for re-engineering as opposed to rationing? And that's really what our confronting cost report from the Commission on a High Performance Health System is about. It is fundamentally about creating incentives, often using existing authorities, for better care and lower cost throughout the continuum of healthcare services. And by the way, not addressing just Medicare, but the entirety of the healthcare system, because it is very hard to reform Medicare independent of the rest of the healthcare system. The first thing it suggests is that we bite the bullet and set a national per capita target for healthcare spending, and that we agree that 18% of GDP spread across our current per capita, our current population, is enough. That we can provide humane and effective care with close to 1 in 5 of our available dollars, and that we can find a way within that envelope, that budget envelope, to do the work we need to do. The second thing it suggests is that there are 3 basic approaches to living with that kind of a envelope for expenditure. The first is to change the way we pay for care. The second is to provide consumers with clear and better choices for getting higher value care and to provide them incentives to pick higher value care. And the third is to reform markets in other ways that are highly dysfunctional. So I'll go briefly through each of these. What about the target? The target is the hardest of these to get your hands around. In Massachusetts, the state has set a target that's at GSP, gross state product, a target for how fast healthcare expenditures should be allowed to grow within the state. It hasn't set up an enforcement mechanism, but by setting the target, it has got the very, very close attention of providers and plans in the state, because it's very clear that as that target is monitored and as providers and payers are held accountable to that target, that there will be accountability in future years. So one way to think about this target at the national level is to view it as a consensus goal. 18% would be fine. It could be set by Congress and or by some public-private collaboration. It should be viewed as a target, not a straitjacket. It should be viewed as a yardstick to assess our performance against. It provides an opportunity to monitor not only national performance, but state and regional performance, and even organizational performance. And it provides an opportunity for us to design policies toward the goal of creating an outcome being a rate of growth in per capita expenditure on healthcare, which is the same as our rate of growth in gross domestic product, no greater than that. The act of reporting, of understanding what the level of performance against this target is by region, by organization, by state, will have a clarifying effect, a mind-focusing effect, if you will, on local elected officials and on payers and on providers of care, and hopefully on the voting public as well. We had the Actuarial Research Corporation cost out a package of policies designed to support the three pillars that I mentioned. One, paying providers differently. The third, providing consumers with more high-value choices and incentives to make those choices. And the third, market-wide actions to improve market functioning. We gave them fairly specific guidance on those policies and asked them to give us some projections on the levels of savings that we might anticipate. And these are the savings numbers that were associated with each of those broad sets of policies. And I'm not going to go into the policies in detail. You're welcome to examine them in our report per se. I just want to note that by far the most effective was payment reform, yielding us over $1 trillion. Next, policies to expand high-value choices. These are over 10 years, by the way. Savings over 10 years. $189 billion from policies to expand and encourage high-value choices, and close to $500 billion over 10 years for improvements in healthcare market functioning. Now, I'll just say a word or two about a couple of specific recommendations that are mostly relevant to the Medicare program per se. The Commission recommended that we repeal the SGR formula, freeze current payments for physicians at 2013 rates, 2012 rates through 2023, recalibrate the relative values for services that are viewed by MedPAC as overpriced, reform the malpractice system through the creation of a no-fault alternative, and that through those kinds of interventions we could save $228 billion in national health expenditures and $155 billion to the federal government over a 10-year period. The Commission recommended a new Medicare Essential plan. One of the great paradoxes of the Medicare system is that it was created in 1965 to be modeled on the then prevalent private insurance plans, specifically the Aetna plan that was available in 1965. But it has come to be completely different in its structure from any private plan that I'm sure any of you have, and certainly any that I've ever had. When I, in my several places of employment over the last 5 years, have enrolled in a plan, I've enrolled in one plan. I pay one premium, and it's all a package, and it covers physician services, laboratory services, hospital services, drugs, other services. It's all one plan. But as you know, Medicare is not one plan. Medicare is an increasingly complicated, impenetrable thicket of multiple plans, each with their own deductibles, coinsurance, out-of-pocket payments, eligibility, formularies, you name it. That makes no sense. It makes no sense that we should require a higher level of wisdom, knowledge, and discerning choice on the part of our most vulnerable population than we do among the working age, healthy population. So they recommended that we create a Medicare Essential plan with a single set of coinsurance and deductibles across all those plans. This be the fee-for-service alternative. It be the default option unless people opted out of it when they enrolled. And by having a single plan with a limit on out-of-pocket payments, you could achieve many administrative savings. You could certainly you can also build in some elements of value-based insurance design, which Medicare does not have right now. You could make more intelligent choices and more predictable choices available to Medicare consumers. You could require valuable additions to the benefit package, like the offering of shared decision-making. You could provide comparative information on care and treatment choices. You could do a lot of things to make this a good plan in the mold of current employer-based insurance. A single prescription drug formulary would be an enormous advance. Savings associated with an essential benefit plan as a opt-out Medicare program would be about $180 billion over 10 years, according to the Actuarial Research Corporation. There are a whole series of administrative costs and complexities that plague our private healthcare system. These need to be addressed. Reducing administrative cost and complexity is a continuing challenge for our private healthcare system. I can tell you, having spent much of my life in a provider organization and having spent the last 2 years in a provider organization, that the costs associated with billing are out of control and pure waste, and that standardized billing forms and standardized claims forms and standardized systems, automated standardized systems for billing are just so long overdue. In order to make these happen, we're going to need to enforce effectively authorities that are already in the Affordable Care Act for reducing administrative complexity in the billing systems of our private payers. We also need to stop the proliferation of quality metrics on a plan-by-plan basis. We are driving our well-intended providers absolutely crazy. The numbers of measures that they have to calculate in different ways, different denominators defined differently, different numerators defined differently, different data required to produce them. We are growing a cohort of data collectors within our healthcare systems that are, again, pure waste. In the well-intended effort to create accountability, but because each private payer has its own measures, Medicare has its measures, different states have different measures of quality, different measures of performance. We are replicating a world of confusion and administrative complexity, which is really unnecessary. So we need to get multi-payer alignment around measures, a core measure set that can change over time, but that providers have some predictability around and can organize themselves around. If we were to do this, it's estimated that we could save $570 billion over 10 years, with $187 billion going to the federal government. So what does this all add up to? 2013 to 2023, $2 trillion, $1 trillion to the federal government, $242 billion to state and local government, $190 billion to private employers, and don't forget people, $537 billion to households. So, obviously these are going to take a huge bite out of our healthcare system, right? Well, hold your horses. $2 trillion is not a lot of money over 10 years. Matter of fact, this is, if we saved $2 trillion, it would be the difference in 2023 between a projected $5.5 trillion in healthcare expenditures and 5.1 trillion in healthcare expenditures. So that little white space between those two lines adds up to $2 trillion. We're not going to break the back of our healthcare system if we save $2 trillion. As a matter of fact, doctors and hospitals will do just fine if we save $2 trillion. Doctors would be paid an estimated $1.1 trillion under the baseline scenario with no reform in 2023, 1 trillion collectively under these proposed reforms. And hospitals, 1.6 trillion under the baseline and 1.5 trillion if the savings that we've estimated were put in place. Now, people need to pull in the same direction. This is a fundamental macrosystem problem that we have. The lack of coordination among payers, the lack of coordination among stakeholders is a fundamental macrosystem problem that needs to be solved before we are able to replicate the positive microsystem efforts that we see throughout our healthcare system. The health insurance exchanges, or now marketplaces, as they're going to be called, are a potential source of leverage to align payers around joint accountability measures, joint value-based insurance designs, and other alignments that are critical to getting some of the administrative waste out of our system. So we're on our way clearly to a new world. I don't mean to underestimate how difficult this will be. The effective implementation of current authorities within the Affordable Care Act, and undoubtedly new authorities as well, will be required if we're going to make the choice to re-engineer our healthcare system rather than to ration care through increasingly reducing the value of Medicare, Medicaid, and private insurance programs. Those are really the choices that we have. You may not believe in or like the particular reforms that are part of the Confronting Cost report, but we think the direction is the direction we need to go. We desperately need to make it possible for providers of care to do the right thing. Thanks very much for your attention.
So we can now open it up to questions, but I want to ask, sorry, Doug, I want to ask the first question, and then I'll turn it over to the audience. So David, the Commonwealth report that you and the High Performing Healthcare Commission, Stu Gutterman, I think is here somewhere, who worked on it extensively, is terrific and has great recommendations. And you mentioned many of them, but many of them will take legislative action. But many of them, I'm thinking, the administration could adopt. And you mentioned that the administration does have a lot on its plate. So I'm taking you back to a couple years ago when you were the national coordinator and you met with the secretary a lot and the president and the acting CMS administrator. What recommendations from your report now do you think you could take to them now to make changes so we don't have to wait until Congress is able to move on some of these ideas?
First of all, thank you for recognizing Stu Gutterman, who is in the audience and played a critical role in putting these report recommendations together. And others from the Commonwealth Fund, Kathy Shane and others were very important. And Glenn Steele from Geisinger and George Halverson and a whole bunch of other folks on the commission were very important as well. So I think that one of the things that the extraordinary authorities that the Affordable Care Act created is the Center for Medicare and Medicaid Innovation. That center has the power to do things that have never been possible for the Secretary to do before. And that is when there is evidence of cost reduction with quality preservation to make those Medicare-wide policies without congressional action. So that's now, the CMMI has been very active. It's done a lot of great things. But as we come up against these very, very painful choices that are highly risky, so we're going to take big risks in the Medicare program by expanding the retirement, by raising the retirement age, by raising premiums, by reducing benefits. These are not risk-free if we take them. Alternatively, we can take a different kind of risk and go a different way, which is to change the incentives, the relative weight that we apply to primary care. The CMMI has launched a terrific demonstration program to greatly augment and align payers in support of primary care in 7 communities around the country. I think that initiative should be greatly expanded. So there are things like this. I think we need to see the aggressive use of the alternative route that is possible within the current ACA framework.
Great job.
Good morning, David, and thank you for your leadership on the task force, and we look forward to your leadership at the fund. I have 2 questions. One is about the target. The president has also put forward a target limit of GDP per capita plus 0.5%, and Paul Ryan has got the same target in his plans. How is yours different, and why is it different?
Well, ours is a national target, not a Medicare target. So that's, I think, the most important difference. Now, there is, of course, it's much easier for the federal government to talk about Medicare. Now, as you know better than anyone, John, we're actually doing better than that target on Medicare right now. So it's not going to be hard to meet that target for Medicare, but our big problem is that our private sector payments are going up at several times the rate per capita that Medicare is going up. So in a sense, we're redirecting attention away from that narrow perspective on the national problem toward where the real problem lies right now, which is for folks who are still privately insured, whose premiums will be equivalent to about 1/3 of their annual income in 2023, even though they may not know it.
And the second question is, one of the most innovative proposals is the new Part E under Medicare. Are there estimates yet of what that would be in terms of a premium contribution for beneficiary?
You know, I don't know it. Stu, do we have those estimates? We don't have them. Sorry.
One would guess it would be expensive, but perhaps not if compared to med sup and out-of-pocket costs and everything else.
And also, it would obviate the need for Medigap coverage.
Exactly. Okay.
Larry Seidman, University of Delaware. I strongly support the Medicare Essential program. When Karen Davis, Marilyn Moon, and others first wrote about it, I thought it was terrific. I'd like you to, though, respond to what would happen next. Let's assume we can get Medicare Essential, one plan under Medicare that covers all of the different services. It makes it simple. I'd propose considering that gradually Medicare Essential gets extended to the entire population so that we have Medicare for all as a single-payer system with the single-payer bargaining power, which has been successful in virtually all the other rich countries in holding medical care spending in the whole country as a percent of GDP to less than 12% when we're up at 18%. We'd have automatic universal coverage. And that's a method. I wish you well on the Affordable Care Act of ways to get costs down from these micro things. But these other countries have gotten their percent of GDP 6 points lower than us for several decades without all these innovations. So I'm not saying we shouldn't do those, but why don't we look at what has worked for the last few decades in other rich countries, and Medicare Essential would be the first step to then move gradually to covering everyone. Your reaction?
It's our next, it'll have to be another report.
Yes.
Well, obviously, it's an idea that has been in circulation. It was actively considered in 2009 and 2010. Was not adopted by the Congress. I don't see a route to getting there in the short term. In the meantime, we do have to worry about these other problems that will affect seniors and poor and the average American, the middle class, and we have to do it within the context of the system we currently have.
Janice.
Hi. Janice Gregory with the Academy. At least some of the things that you're talking about rely on the primary care network. And from everything I've seen, and we have a shortage of primary care physicians that is not getting better, it apparently is getting worse. Have you looked at, what are we misusing them? Do we just have a real shortage? Is that something else we need to be worried about, or where is all that?
The answer is all the above. We misuse them. We use them, and I spent 35 years as a primary care physician. We use them to do things that are routine and unnecessary for them to do. Routine preventive screening, routine management of chronic illness that is not hard or difficult or complicated to do. So we definitely need to move from the solo physician model, and often even within organizations, the individual physician functions as a solo physician without being incorporated fully into a team. So we need to make better use of our current productive resources. We need to make primary care as attractive in the United States as it is throughout the world, throughout the developed world, where primary care and specialty salaries are comparable, both lower than they are in this country, but comparable, so that young people who want to be in medicine are as interested in choosing primary care as they are in becoming a cardiologist or a neurosurgeon. And then I think we do need to make better use of the capability of nurses and nurse practitioners and physician assistants to provide primary care. There are differences in what physicians and other primary care providers can do. Those differences are important to preserve, but they should be complementary. I think if we had an adequate primary care workforce, a diverse primary care workforce, the shortage of primary care physicians would be less acute.
Joanne.
Hi, Joanne Lind from Altarum Institute Center for Elder Care. I guess I'm asking perhaps for another report just like the other person was, but it seems that in your microsystem and macrosystem vision, which is a very appealing vision, one of the really important questions is the boundaries of those systems. And we sort of assume our heritage and say, well, that's about medical care and medical care coverage. But at least for some populations, the most expensive populations, the mentally ill, the frail elders, the seriously disabled, the core question, it seems, is the boundary of those systems. And if we think about the system from the perspective of the primary care doc I was or you were, we tend to see it through a medical lens. But it may well be that our biggest problems are the things we are leaving outside of our descriptions of the systems. The housing, the hands-on care, the direct care workers, the availability of money for food. One of our care transitions communities made its biggest impact by getting rid of the waiting list for Meals on Wheels. So sometimes I think when we see it through the medical lens, we're missing the point. And that might be the more fundamental reform that we need to re-estimate. What could we achieve if we took seriously the macrosystem and the microsystems being broader than we now see them?
Well, I think there's a way of discussing that issue within the context of the paradigm of macrosystem and microsystem. If we had macrosystems that paid for care without prejudice as to what was provided, capitated, value-based, then it would be up to the caretaker and the cared for person to decide which services were most valuable. And you would see, I think, remarkable innovation. The use of less trained personnel to provide services in the home, the provision of air conditioners for to avoid visits to the emergency room in hot summers and avoid dehydration and the consequences of hyperthermia. So I think you see a lot of very interesting innovation that is prevented right now by the way we design our payment systems, that particular macro system.
Jenny.
Yes, thank you. Jenny Chin-Hansen, currently with the American Geriatric Society, but I spent about 25 years with the Unlock, the original PACE program. And so it's interesting to hear the conversation here because it is a fully capitated, dual eligible program, as you probably know. But I want to thank you because your visuals was something that was so simple on one level, but it helped actually me further crystallize the question as to why the PACE program hasn't been able to grow much more quickly. And the whole microsystem aspect was studied actually by Dartmouth and found that, but it was the bigger structure above and fighting all the other, rather codified structures that always kind of fought against that whole process. But I wanted to just give the narrative of some key things that we're shooting for in the example that you had, even with medical malpractice as an example. In the 25 years I was there, and as our program got increasingly diverse over diverse populations, we never had a lawsuit in a totally managed care program. Whose endpoint was actually death for people, so I mean, which tends to be a contentious period. The other thing we were able to do, according to what you just shared with Joanne, is the ability to have primary care be at the core of it. So we had core physicians, but with nurse practitioners and others doing the routine kinds of things and saving kind of the educated skill and role of medicine in a team-based approach with other people, not the least of whom, going back to the example of other people, our drivers ended up being our first set of eyes to find differentials that were reported back and then people took attention to. So it's possible to do these things. And the third thing about quality metrics, I have the fortune of sitting on NQF's dual eligible map process right now. So I have come from the Unlock or PACE model where we had probably 10 metrics that we probably kept track of all the time. And a metric that would probably not show up in an NQF, to give you an example, is that of retention of workers and retention of direct care workers in the area of frail older people tends to circulate from anywhere from 75 to 125% a year. And so we had people stay with us for decades to do that. So it's possible, but I must say it's very hard. Probably the good news at the moment is that it's practiced in now 29 states with 88 programs and about 30,000 members. I'm no longer connected to it, so it is possible, but I must say our legislation passed in 1997, and this is where we are today with that kind of growth. But a separate question is more with the rate of inflation growing, much more slowly than in the past. What do you see the role of IPAB being kind of on a go-forward basis?
Personally, I would love to see IPAB in place as a stopgap against. It's the Independent Payment Advisory Board. Sorry not to make that clear. It's part of the Affordable Care Act. It is a non-congressional organization, not so different from MedPAC, the Medicare Payment Advisory Commission, but with the authority to essentially force Congress to adhere to a given level of increase in the rate of Medicare costs. So it's not, it doesn't itself have control over it, but it can force Congress to either adopt or not adopt recommendations that conform to a rate of increase in Medicare costs. It was one of the reasons why the Congressional Budget Office scored savings in the Medicare program, because it gave credibility to the goal of keeping Medicare rates of increase per capita at a certain level. So some of those $716 billion in savings that were batted around during the last election were related to the presence of IPAB. Now, IPAB is so far a fiction because the Congress has been unwilling to appoint anybody or allow the president to appoint anyone to it. So it's interesting as an idea, it's interesting as a precedent for what we could accomplish and for the general goal of setting a target. But I don't think it right now has the political, it's not likely to be put in place in the short term. There may be others in the audience who have different opinions about that, but it's, I think, a very interesting innovation in governance. Unfortunately, it's somewhat stillborn.
Hi, Christine Quino from NASI. You had knowledge gap in one of your slides as an obstacle, and so I have a two-part question. One, what's being done to bridge that knowledge gap, especially amongst, say, physicians and maybe more importantly, students who are studying to be physicians and healthcare providers? You know, I'm always amazed at how many I encounter who know that the government runs Medicare but have no idea that private plans have anything to do with it. And two, is there a role for the academy in helping to bridge that gap?
Well, the knowledge gaps are many, and you've referred to one of them. I spent many, many years teaching medical students and teaching house officers, and you're absolutely correct that their level of understanding of the healthcare system is minimal, and they have no opportunity to improve it for the most part, though some schools are changing. The knowledge gaps, though, that I think are even more important are the gaps that prevent well-trained professionals, whether they're nurses or physicians or respiratory therapists or physical therapists, from knowing what to do for their patients. We recently had this national tragedy of contaminated injectables that originated from a compounding pharmacy in the state of Massachusetts and resulted in central nervous system infections, fungal infections, and throughout the United States, several hundred folks have died, many others have had terrible illnesses. They were used to inject backs in people who had back pain. Now, 80% of the U.S. adult population at some point in their life will have back pain. It's not a rare event, it's the modal event in the natural course of aging in the United States. It turned out that if you looked at the literature about that process, the process of injecting backs, the literature is very controversial. It's not at all clear that it's useful. So the awful thing about these complications is that they may have been associated with treatments that are not efficacious. It's a classic example of a risk, of a harm associated with a treatment about which we really need to know more. The Patient-Centered Outcome Research Institute, funded under the ACA, another very important macrosystem change, is going to be trying to fund that kind of work, comparative work. But there's a macrosystem deficit in it, which is it is forbidden by law to study the cost associated with any treatment. And Medicare is forbidden by law to take into account its recommendations with respect to what's efficacious and what's not. And this is all a result of the rationing discussion. We're quite happy to ration care by taking it away completely from people, by raising the retirement age, whatever, but we're not willing to ration care by using evidence to inform coverage decisions. That's not even rationing, that's good common sense. So that's the kind of knowledge that I think we most desperately need. I saw in my own practice, using an electronic health record, in my work as national coordinator, the way in which informing physicians electronically or informing nurses electronically about what the best way to treat a condition is at the point where they are making a decision about what to do, the way that can change behavior in a very positive way, reduce cost and increase quality. But there is very little that we have to tell physicians and nurses about what to do with assurance. Jack Wenberg, the great epidemiologist of care, responsible for the Dartmouth Atlas and so many other important things, used to talk about medicine as islands of knowledge in a sea of ignorance. And that still is the case for so much of what we do. So we desperately need more knowledge about how to make care better.
Can you make it really, really quick, because we're supposed to adjourn?
Well, I guess if it has to be really, really quick, then here's the question. First of all, you guys have done so much great work over the years, both you personally and Commonwealth. But I guess I was really struck by your citing George Halverson and the idea that lower prices are the same as rationing. Because, again, lower prices in a lot of situations, I mean, you can make the assumption that a specialist who can only make $400,000 a year instead of $500,000 a year would go out of business, but I'm not convinced. And so I know that, in fact, you want to rationalize the prices and fix the ruck and all that kind of stuff, but are you comfortable with lower prices as a form of rationing?
Well, you've made the point that that's not a totally accurate statement, but it is accurate for Medicaid. It is, I think, increasingly going to be accurate for Medicare. I think if we've marginally increased what primary care physicians are paid under Medicare, but we haven't increased that enough to make it an attractive form of service for primary care physicians. And I am very concerned that we will reduce prices to for some kinds of payers and not for others, and that's going to ration care to some groups but not to others. So am I comfortable saying price reduction is rationing in every circumstance? No. But in the context of the conversation I think that we're having in the public sector right now, yes, I am concerned about that. And our recommendations do argue for the reduction in some prices that have been determined to be overpriced.
David, thank you so much. This has been terrific.
You are so good.
So my instructions are to tell you that you're to go outside and pick up a box lunch, right? And then bring it back in here. And our lunch keynote with Suzanne Mettler and Alice Rivlin will be at 12:15.